Welcome to This Explainer. Today, we're diving straight into the incredible plumbing of the human body. We'll be looking at exactly how the genitourinary system works, and more importantly, what happens when it completely breaks down.
Now, before we can truly understand how to manage a devastating event like acute kidney failure, we've got to establish the sheer amount of work this system does for us every single day. I mean, what actually happens when your body's ultimate filtration system suddenly goes offline?
Here's our roadmap for today's explainer. First, the baseline, normal physiology. Second, system crash, acute kidney failure. Third, filter malfunctions, glomerular syndromes. Fourth, blocked pipes, obstructive disorders. And finally, microbial invaders, urinary infections.
Let's kick things off with part one, the baseline, normal physiology.
While we typically just think of the kidneys for urine formation and waste excretion, they actually perform 10 massive functions. We're talking about controlling your blood pressure, regulating calcium and phosphorus balance, and maintaining your body's acid-base levels by conserving or excreting hydrogen and bicarbonate ions. They literally synthesize active vitamin D and regulate red blood cell production. Understanding this baseline is absolutely crucial for clinical management, right? Because it explains exactly why patients in renal failure become profoundly anemic and hypocalcemic. The kidneys just stop producing these vital regulating factors.
It's basically a complex hormonal command center that constantly monitors and adjusts your blood pressure and plasma volume. For instance, when blood pressure drops, renin is released, triggering a cascade that leads to vasoconstriction and water retention. On the flip side, atrionatriuretic peptide, or ANP, responds to high blood pressure by promoting vasodilation. And if calcium levels dip, parathyroid hormone steps in to reabsorb it. From a nursing perspective, this delicate balancing act is exactly why we have to meticulously monitor daily weights and blood pressures in our renal patients.
So producing the normal 1 to 2 liters of daily urine is actually a highly structured 4-step process. It starts with a massive 100 to 125 milliliters of blood flowing through the kidney's filter every single minute. That right there is your glomerular filtration rate, or GFR. Clinically speaking, GFR is the primary diagnostic lab value we use to stage kidney disease. From ultrafiltration to selective tubular reabsorption, secretion, and finally excretion, every single drop of fluid is meticulously processed before it ever enters the collecting ducts.
Moving on to part 2, system crash, acute kidney failure.
To really understand acute kidney failure, it helps to think of a city's water system. We divide it into 3 distinct categories. Prerenal is essentially a drought, where shock, hemorrhage, or severe hypovolemia stops blood from reaching the plant altogether. Then you have intrarenal, which is direct toxic or ischemic damage to the actual kidney tissues themselves, maybe from prolonged ischemia or nephrotoxic drugs. Finally, postrenal is like a blocked pipe leaving the facility, so a sudden obstruction of urine flow due to things like kidney stones or an enlarged prostate. Medical management here is all about quickly identifying which of these 3 locations is causing the crash so we can reverse it before permanent tissue death occurs.
The crucial point here is that when these failures happen, the glomerular filtration rate drops sharply. Patients will often experience oliguria, meaning their urine output plummets dangerously low, specifically less than 500 or 400 milliliters a day. This leads to a toxic buildup of urea and creatinine in the blood, a state known as azotemia. That literally translates to abnormally high levels of nitrogen-containing compounds in the blood. This retention triggers severe metabolic acidosis and life-threatening electrolyte imbalances, like hyperkalemia. That's exactly why immediate nursing management requires incredibly strict fluid intake and output monitoring alongside potassium restrictions.
Now, if a crash does happen, it progresses chronologically through 4 phases. It starts with the initial insult, then moves into a life-threatening oliguric phase where uremic symptoms really start to show. Patients might become confused, lethargic, and extremely itchy. During this phase, they often require temporary dialysis support and diuretics. After that, if the patient survives and the underlying cause is managed, they enter a diuresis phase. Here, nursing care shifts dramatically to preventing dehydration and hypokalemia because the kidneys are suddenly dumping massive amounts of fluid. And finally, they enter a long recovery phase.
Let's look at part 3. Filter malfunctions, glomerular syndromes.
Zooming in on filter malfunctions within that intrarenal category, 2 complex but very distinct syndromes emerge, and they look quite different clinically. We have nephritic syndrome and nephrotic syndrome.
Let's break those down. While both involve damaged glomeruli, nephritic syndrome is basically an inflammatory response.
It causes you to leak red blood cells into the urine, which is hematuria, alongside oliguria and hypertension. On the other hand, nephrotic syndrome involves increased permeability that heavily leaks proteins. We're talking over 3.5 grams in 24 hours. Losing that much protein causes massive fluid shifts, leading to severe peripheral edema, low serum albumin, and hyperlipidemia. Because nephrotic syndrome causes such massive fluid shifts and swelling, medical management relies heavily on ACE inhibitors to reduce protein loss, diuretics to manage the excess fluid, and strict dietary sodium restrictions.
All right, on to part 4. Blocked pipes, obstructive disorders.
Moving past the microscopic filters, obstructions can actually happen anywhere along the tract. They can be due to highly concentrated diets forming calculi or stones from high oxalates and purines. But they can also be caused by structural issues like tumors, strictures, blood clots, or benign prostate growth. Diagnosing these blockages usually involves a KUB X-ray or an ultrasound. And remember, for patients with suspected calculi, a primary nursing rationale is straining all urine to capture those stones for lab analysis.
Take benign prostatic hyperplasia, or BPH. The prostate physically squeezes the urethra. As men age, changes in active testosterone and estrogen levels promote prostate cellular growth. Because of this squeeze, the bladder's detrusor muscle has to work much harder to force urine out, which leads to incomplete emptying, significant resistance, and urine retention. Medical management for this often involves alpha blockers to relax the prostate muscles, or in severe retention cases, immediate catheterization to empty the bladder.
Now, if those pipes stay blocked, we run into a dangerous condition called hydronephrosis. The backed-up pressure literally suffocates the kidneys, causing intense flank pain, nausea, and potentially complete anuria. If both kidneys are affected, the patient will rapidly exhibit signs of acute renal failure. To save the kidneys, physicians have to immediately relieve that pressure, often by placing nephrostomy tubes directly into the renal pelvis to bypass the blocked ureters entirely.
Finally, Part 5. Microbial invaders, urinary infections.
Our final category of malfunction happens when the normally sterile urinary tract is breached by pathogenic microorganisms. We can neatly divide these infections geographically. Lower UTIs inflame the bladder, prostate, and urethra. Upper UTIs, however, are far more severe because the bacteria have actually reached the renal pelvis and kidney tissue itself, like we see in conditions such as pyelonephritis. Diagnosis heavily relies on a urinalysis showing leukocyte esterase and nitrites, followed by a culture to identify the specific microbial invader so targeted antibiotics can be started right away.
And here is the real aha moment where everything connects. When conditions like strictures or BPH cause urine to pool and stagnate rather than empty completely, it creates the absolute perfect breeding ground for these severe microbial invaders. A fully functional urinary system relies on appropriate filling and complete emptying. Without that constant flow, recurrent infections are practically inevitable.
So, knowing how this intricate plumbing system relies on constant flow and perfect pressure, how can we better recognize the early warning signs before a total system crash? Understanding the delicate balance of this baseline physiology lets us see exactly why symptoms like altered output or flank pain demand our immediate attention. Recognizing the signs of a dropping filtration rate or a looming obstruction could literally save your patient's kidneys. So what early warning signs will you be keeping an eagle eye out for on your next shift? Thank you so much for joining me for this explainer, and keep questioning how things work.